say that Nightingale not only would be very impressed with the way that South Australia and our healthcare colleagues have been coping with the pandemic, she would be very impressed that we all are starting to take hand hygiene seriously, social distancing seriously, and getting that good dose of outside fresh air to keep everybody as fit and as healthy as possible. I also think she would be very impressed with what Jeroen is going to be talking about, because his work, as you will hear, brings together the qualities of erudition, of research, of compassion, of pragmatism, and of practical problem solving that all good nursing leaders demonstrate. So I would like to invite Jeroen to tell us about, I'll tell you something about him, but then I'm going to ask him to present. Now, Jeroen holds the inaugural Leo J. Maher Cardiovascular Nursing Chair between Flinders College of Nursing and Health Sciences and the Department of Cardiology at the Royal Adelaide Hospital. Jeroen's major interest is in integrated care in chronic cardiac conditions, and in particular, cardiac arrhythmias such as atrial fibrillation. He is also affiliated to the Centre for Heart Rhythm Disorders at the University of Adelaide and holds a Future Leader Fellowship from the Heart Foundation in Australia. I would also like to welcome you to our special panelists who we will hear from a bit later. Thank you so much for joining us, retired cardiologist, Dr. Leo Maher, Professor Prash Saunders, who's Professor of Cardiology at the University of Adelaide, Ms. Imelda Lynch, who's the CEO of the Heart Foundation of South Australia and Northern Territories, Catherine Zietz, who's the Transformational Change Leader at the Central Adelaide Local Health Network, and Donna Stevens, Director of Nursing, Heart and Lung from the Royal Adelaide Hospital. Now, after you hear from Jeroen, we will be inviting our distinguished panelists to get involved in a question and answer session. So we would hope that the 100 plus of you who are online and on Zoom can send your questions in. Now, I'm not saying that we'll answer all 100 if there's 100 questions, because for us it will soon be time to sort of, dare I say it, have that medicinal glass of wine. But we know that Jeroen will be sticking to his very strong Dutch coffee. So Jeroen, please, we're delighted that you have agreed to present, and please, we're looking forward to hearing what you have to say.
Thank you very much, Alison, for the kind introduction, and thank you also for the panel to be there. Ladies and gentlemen, welcome to this public lecture. And I agree, Alison, that it would be too early for a glass of wine for me, as it is still morning in the Netherlands, but the coffee is doing its work. So let me just share my screen. And I hope you can see my slides. Perfect. So again, thank you for the opportunity to present on integrated care. And let me take you on a journey to reimagining care to manage our patients with cardiovascular conditions, and in particular, atrial fibrillation. As Alison just said already, my work is mainly focused on cardiac arrhythmias and then mainly in atrial fibrillation. And I will use atrial fibrillation as an example throughout this presentation, but keep in mind that the approach that I will talk about can be translated into other chronic conditions. So currently we're facing actually an aging population, and it is expected that by 2050, there will be 22% of the total worldwide population aged 60 years of age or older. And this actually goes hand in hand with an increased mortality of cardiovascular conditions. And looking at the right-hand side on the bottom, there's atrial fibrillation and flutter, which shows a steep increase in mortality cases over the years between 1990 and 2013. So atrial fibrillation is the most prevalent cardiac arrhythmia, and it's associated with cardiovascular morbidity, but also with an increased risk of mortality, as we just saw. And I think the most severe complication is an ischemic stroke due to atrial fibrillation. So patients with AF, as we call it in short, have a 5 times higher risk of stroke compared to those patients without the arrhythmia. And the guidelines actually recommend a comprehensive treatment approach which goes beyond the management of atrial fibrillation alone. So if we look into the figure on the right-hand side, we can see there the treatment parts, where we can see heart rate assessment and symptom assessment by applying a rate control or a rhythm control strategy. But beyond that, it's really important to assess the stroke risk based on underlying cardiovascular conditions and apply appropriate anticoagulation to prevent strokes in patients with atrial fibrillation. And finally, to manage precipitating factors such as underlying risk factors and lifestyle changes, with the aim to reduce the cardiovascular risk, which can reduce the burden of atrial fibrillation as well. So the aim of this comprehensive approach is not only to improve life expectancy in patients, but also to improve the quality of life. As I just said, atrial fibrillation is the most prevalent cardiac arrhythmia. And to give you some numbers, in 2010, there were 33.5 million individuals affected with atrial fibrillation globally. And currently, it's the most common cardiovascular cause for hospitalization. So if we look in the figure, this is data from Celine Gallagher from the Center for Heart Rhythm Disorders, who looked into a 20-year period of time in Australian hospitalizations. And atrial fibrillation is here represented in the blue bars. And we can see a steep increase over the years. And actually, atrial fibrillation-related hospitalization is now outnumbering hospitalization for major cardiac events such as heart failure and myocardial infarction. And you will not be surprised that this goes hand in hand with an increased cost, given that hospitalization is the main cost driver in AF management. So if we look into a caring future for atrial fibrillation, I think we also need to ask ourselves the question that if we see that atrial fibrillation is a complex condition and requires a complex management approach, then the question is one single healthcare professional able to address this complex approach by him or herself, or do we need to explore novel models of care? And I think the answer to this question should be yes. So integrated care has been identified as a suitable approach to manage patients with chronic conditions such as atrial fibrillation. And it's actually a worldwide health reform and implementing of novel models of care to really prevent fragmentation of care. So integration means to improve access and quality of services, but also to improve efficiency and outcomes of care. And the World Health Organization has defined this as a concept bringing important fundamentals to really across the continuum of care. And if we look into the figure, we can see a patient-centered approach with the patient with a chronic condition in the center of the approach and the care arranged around the patient and having the patient involved. So there's coordinated services, there's team-based approaches, and also the use of technology is more and more important. Now in 2016, the European Society of Cardiology updated their guidelines for the management of atrial fibrillation, and they adopted this integrated care approach for atrial fibrillation management. And in 2018, the first guidelines for the diagnosis and management of atrial fibrillation were developed in collaboration with the Heart Foundation of Australia and the Cardiac Society of Australia and New Zealand. And they have adopted this approach as well. And this approach consists of 4 crucial key fundamentals. First of all, a multidisciplinary team approach. So it's no longer one single healthcare professional providing this complex care, but there's a collaboration between cardiologists, electrophysiologists, nurses and allied health professionals, but also other specialists like neurologists or internal medicine, or generalists like the general practitioner. They all work together in a collaborative practice model. Then secondly, a patient-centered approach. So it's really crucial to have the patient actively involved in their care process to help the team improve outcomes of care. But before patients can take on such an important role, they need to understand their condition, so atrial fibrillation. They need to understand their treatment, but also what they can add to improve their care outcomes. And therefore, it's crucial that we provide patients with structured information and education and empower them to undertake self-management, looking into adherence to their medication, for example, but also looking into risk factor management and lifestyle changes. Then thirdly, e-health to support the management of atrial fibrillation and in fact to support integrated care. So there's numerous applications available for patients to use, for example, to provide them with education and to guide them in self-managing their condition, but also decision support technology is available to help decision-making within the treatment team. And then finally, a comprehensive care approach, as I just alluded to, but also access to all treatment options. And the guidelines actually state that an integrated care approach is recommended in all patients with atrial fibrillation, and it aims to provide patient-centered, comprehensive treatment delivered by a multidisciplinary team. Now, this is a mouthful, and I would like to share with you my thoughts of how this would work in practice. So if we have a patient-centered approach, then we should have our patients in the center of the care, in the middle, with around the patient those specialists that can be involved in the management of atrial fibrillation. And this is really based on the individual case of the patient. So it can, for example, be a primary care physician, can be a pharmacist or a neurologist, really depending on the individual case. But directly around the patient, there's a cardiologist or an electrophysiologist closely collaborating with an AF specialized nurse, and they are closely working together with an AF patient steered by decision support technology. So for example, the nurse could focus on educating the patient and preparing them to undertake self-management and coordinating the care, while the cardiologist could focus on the medical part of the treatment. So I think in the most optimal case, I think all patients with a new diagnosis of atrial fibrillation deserve at least one visit in such a specialized approach to do a full diagnostic assessment, to initiate appropriate and comprehensive treatment based on the guidelines, and really focus on engagement with the patient to identify their values, their needs, and their preferences, educate them and empower them to undertake self-management. A structured follow-up, and this is also very much important, and then in the appropriate setting, and with that I mean in a hospital setting, through telemonitoring, or in general practice. And this comes down to redesigning practice and healthcare reform, and we'll look into that in the next few slides. If we look into evidence on integrated care in atrial fibrillation, the evidence is scarce. There's a handful of trials that focused on this, and in respect to the time, I would like to focus on two trials that have been performed in the Netherlands. So this one is reported in 2012, and I was involved in that myself. This is a study that was performed in the Maastricht University Medical Center in Maastricht, where we developed a specialized AF outpatient service based on the elements of integrated care. And we actually performed a prospective single-center randomized controlled trial where we recruited patients with newly diagnosed atrial fibrillation who were referred for AF management in the cardiology department. So we recruited 712 patients with atrial fibrillation and randomized them into the integrated specialized nurse-led AF clinic versus usual care provided by a cardiologist. And we followed them for at least 12 months, and the primary endpoint was a composite of cardiovascular hospitalization or mortality. Now, if we look into the figure, we see the Kaplan-Meier curve focusing on cumulative incidence of this composite endpoint. And we see at final follow-up that this endpoint occurred in 14.3% in those patients receiving care in the specialized AF clinic versus 20.8% in those patients receiving usual care. And this led actually to a 35% relative risk reduction in favor of the AF clinic based on this primary endpoint. In a recently performed post-hoc analysis, we also looked in all-cause mortality, and again, we saw a significant reduction for those patients receiving care within the AF clinic. And this led to a 56% relative risk reduction, again, in favor of the AF clinic. So actually, with this trial, we showed superiority of this specialized AF clinic in terms of hard endpoints. Now, last year, the RAISE-4 trial was presented as a late-breaking clinical trial at the European Society of Cardiology. And this can be seen more or less as a follow-up trial of the trial that I just presented. So they looked into the use of the AF clinic as well versus usual care, but they performed a prospective multi-center randomized control trial in 8 centers in the Netherlands. So they had a longer follow-up, at least 36 months, and their primary endpoint was, again, a composite of unplanned cardiovascular hospitalization or mortality. And as we look at the Kaplan-Meier curve, we can see that both arms end very closely to each other, indicating not a big difference between the arms. And again, there was no significant difference between the care in both groups, with a 15% relative risk reduction in favor of the nurse-led care. Now, the researchers looked into the data a bit further, and they looked into the effect with integrated care in experienced centers and less experienced centers. And experienced centers were defined as those having experience with integrated care. These centers had already an AF clinic and knew how to deal with the redesigning healthcare, so to say. And what we see is that the experienced centers perform well with the nurse-led approach, but in the less experienced centers, it's the other way around, and usual care is slightly better compared to the nurse-led care. So this actually demonstrates, I think, the importance of implementing this approach, also the difficulty of integrated care and the complexity of AF management. And I think this also asked for further investigation into integrated care in atrial fibrillation. Now, another important factor within the comprehensive management approach for atrial fibrillation is risk factor management. And I think this topic has been really put on the world map by the Center for Heart Rhythm Disorders under the guidance of Professor Prash Sanders. So looking into modifiable risk factors such as obesity, underlying conditions like hypertension, diabetes, and hyperlipidemia, but also the use of alcohol and smoking. The idea behind this is that this leads to mechanistic changes in the heart, which leads to the development or even worsening of atrial fibrillation. And management of this in a specific risk factor clinic has been demonstrated in numerous studies performed by the Center for Heart Rhythm Disorders, and really overall showing improved outcomes in patients with atrial fibrillation, also improved outcomes after ablation procedures, for example, and improved outcomes in terms of freedom from atrial fibrillation and improved quality of life and global well-being. So this is really an important aspect that has to be fused into the AF clinic that I reported just before. There was some risk factor management in these clinics as well, but not as aggressive as this risk factor management approach presented here. As Alison just explained, I was recently appointed the inaugural Leo G. Maher Cardiovascular Nursing Chair in collaboration with Flinders University and the Central Adelaide Local Health Network. And I'm really, really proud of this collaboration and proud of this post. And I think there's a lot of great work that can be achieved with that. So in this post, I'm actually looking forward to build a collaboration between academic and clinical centers. So in this case, Flinders University and the centers connected to Callan, specifically focus on AF management, but also in looking into associated cardiovascular conditions. And I think it will enable me to create synergies to use the concept of evidence-based practice, but also practice-based research, and bring research back into research, bring research back into practice, I would say, and look into practice for research questions to investigate in the academic setting. So the plan is to develop and implement novel models of care delivery, where there's a specific role for the nurse and allied health professionals within the multidisciplinary team. And based on these approaches, this will generate research as well. So one of the first steps that I'm working on now and that I would like to implement once I'm back in Adelaide is the iCare AF clinics, integrated care in atrial fibrillation, in terms of a rapid access AF clinic outpatient service where we integrate specific AF management with risk factor management, and then following the fundamentals of integrated care as mentioned here before, and mentioned before. And we are actually using technology there, preparing technology there to help decision-making within the team, but also to provide patients with education and to enhance their self-management. And I would like to show you how that would look like, that patients use that in their own homes to support their self-management. So we have educational parts in that application where patients can tap into and looking into what is atrial fibrillation and what does AF feel like. They can look into like short videos explaining what is sinus rhythm and what happens when the heart is in atrial fibrillation and how does that relate to my symptoms that I'm experiencing. But we also want the patient to work with the app. So we want them to keep a diary where they keep a list of their exercise, what they've been exercising and how much, a food diary, if they had any episodes of atrial fibrillation and how they felt with that and what they did to get over these palpitations, but also to record their vital parameters such as their blood pressure. And here you can see, for example, the calculation of their BMI based on health, height, and weight. Of course, with this trial, we would like to do research, but first we would start implementing this at the Department of Heart and Lung at the Royal Adelaide Hospital in the outpatient service, and then distribute this to sites across South Australia, interstate, and potentially New Zealand as well. We're planning a randomized control trial where patients will be randomized to the intervention AF clinic versus the control usual care, stratified per center, and we would recruit 1,376 patients with a confirmed diagnosis of atrial fibrillation who are referred for management of their atrial fibrillation. The primary endpoint is a hard endpoint, all-cause hospitalization and mortality, a combined endpoint. But then the secondary endpoints, we really would like to look into patient-reported outcome measures such as quality of life, anxiety and depression, amongst others, but also look into guideline adherent therapy, the change in risk factor status, and the amount of healthcare utilization and the cost effectiveness, of course, to look into the burden on the healthcare system. I stressed it before, but I want to highlight it again, but patient involvement is really crucial to improve outcomes of care. So this is one of the pillars of integrated care, but I also would like to use that as a bridge to a study that I would like to share with you that we performed within the Center for Heart Rhythm Disorders. So this study really looked into the importance of having patients on board and providing them with education on atrial fibrillation. So the HELP AF study is the home-based education and learning program for atrial fibrillation. And what we did in this approach is that we recruited patients who presented to 6 hospitals in South Australia with a primary diagnosis of atrial fibrillation. And these patients were randomized into the HELP AF intervention versus the usual care control group. So patients in the HELP AF intervention group received a home visit by a registered nurse or a pharmacist 1 to 2 weeks post-enrollment. So these educators were trained in the method of structured educational visiting, and they were upskilled in the management of atrial fibrillation. So this was a 60 to 90 minutes exchange of information between the patient and the educator in the patient's home. where the educator discerned the motivational factors in patients to achieve behavioral change and delivered the education by 4 key points that were pre-specified to allow the change to occur. And I will show you these key points in the next slide. Then 7 to 8 weeks after enrollment, there was a second home visit to really consolidate the things expressed in the first home visit. And during the whole follow-up, all patients received standard management by a primary care physician and or a cardiologist. The primary endpoint of this study was a total unplanned hospitalization and quality of life. Now, I just referred to 4 key messages that were provided to the patient in their own home, and these were: take your AF medication as prescribed to reduce the symptoms and risk of stroke. We also talked about that stroke-preventing medications could reduce the risk of stroke by up to 60 to 70%, and that's why it's important to take the medication. We introduced a healthy lifestyle to reduce the risk of stroke and AF becoming more severe. And we also provided them with an action plan that patients could follow during episodes of atrial fibrillation. Then, together with a multidisciplinary team and patients, we created a patient educational booklet that you can see here on the right-hand side of the screen, which was called Living Well with Atrial Fibrillation. And this was used actually by the educators to provide patients with education in the home situation, and was also left with the patient for further reading and reference after the visit. Now, the personal action plan, we came up with an acronym REST, and this action plan can be followed by patients during an episode of atrial fibrillation with similar symptoms as previously experienced by the same patient. So we told the patient, first of all, to not stress, but relax and stay calm. We teach them to estimate how to estimate their pulse rate, because they might require rate control during an episode of atrial fibrillation. And we also encourage them to see their personal general doctor or their cardiologist to complete this personal plan with actions to be done during an episode. For example, taking additional medication. And then patients had access to a 24-hour Help AF line, a telephone line. If they required further information, they could speak with the cardiologist on call. Now, here we can see the final result of the primary endpoint, unplanned total hospitalization, and we actually looked into an incident rate ratio, which was 0.74, which actually relates to a 26% reduction of unplanned total hospitalization in favor of those patients in the Help AF intervention group. We also looked into pre-specified factors that could influence hospitalization in patients, and we found that there were predictors of reduced hospitalization, and this was found in the level of education, so secondary and tertiary completed education, and if patients were not living alone. Looking at quality of life, overall we saw small improvements over time in all skills in favor of the Help AF intervention group, but there were some significant improvements in the 24-month and the symptom domain, but also in the treatment concern at 3 months follow-up and 24-month follow-up. And I think what the Help intervention actually showed is that personalized structured education is an essential component of care for individuals with atrial fibrillation. And that is my message actually through integrated care as well. And that's why I wanted to highlight this study and this presentation as well. And then COVID-19 happens, which impacted to all of us. It impacted the world, I think. And my impact was that I traveled back to the Netherlands to be close to family, but it also brought opportunities. As we can see with this presentation, work continues online, but I also got involved with an intervention born out of emergency that was developed by the Department of Cardiology with the Maastricht University Medical Center in Maastricht here in the Netherlands, and you can see that on the image in the middle. And this approach is called Telecheck AF. So what happened in the Maastricht institution is that all outpatient consultations for patients with atrial fibrillation were cancelled for patients with AF due to the COVID-19 situation, and they were converted into teleconsultations. But while cardiologists and AF nurses from the AF clinic were calling patients, they had no information about heart rate and heart rhythm because it was not possible to see patients in the hospital, and it was not possible to do an ECG to have that information present. So we found actually an app that can be downloaded on a smartphone and that uses PPG signaling. And what patients can do, using the camera in the phone, and what patients can do is just putting their finger in front of the camera and measuring their heart rate and rhythm for 60 seconds. I would really like to tell you a bit more about this approach in the next slides. It started actually with a tweet from cardiologist Dominic Lins, who's one of the initiators of the approach, on the 17th of March, who said, like, we are doing teleconsultations, but we don't have information about rate and rhythm control in patients with AF. And he actually asked his colleagues, like, how do you manage that in practice, or how would you manage that? And the answer, like more than 50% of the responders answered through wearables. Now, we have a number of wearables that use ECG technology, but in our case, we use PPG technology, and PPG means photophotosmography. And this is that their sensors use a light-based technology to sense the rate of the blood flow as controlled by the heart's pumping action. So if the patient puts the finger in front of the camera, the PPG technology is able to measure heart rate and rhythm in this patient. Research has been done to test the accuracy of AF detection by smartphones, and the FibriCheck that we use has a sensitivity and specificity between 96 and 97%, which is relatively high. And then the Telecheck AF approach was born under the slogan, keep our patients out of hospital during COVID-19. So Telecheck AF is an approach with three major components. First of all, as I just mentioned, teleconsultation, because the face-to-face consultations were canceled. So patients received a call by their cardiologist or their AF nurse from the outpatient clinic. But given that there was no information through an ECG on heart rate and rhythm, we actually introduced the app and we did that on demand and actually on prescription. So we gave patient a prescription in terms of a QR code that they could download the app and could activate the app, where we asked them to measure their heart rate and rhythm 7 days prior to their teleconsultation, 3 times a day, and do additional recordings if they had any symptoms. That is check, the second step. And then the third step is AF, which refers to comprehensive AF management that we just discussed from the guidelines, and that is here provided through teleconsultations. But of course, we had to initiate this with the patient. So we asked our secretary to serve as a case coordinator. And what she did is she contacted all patients 1 week prior to their scheduled outpatient appointments and explained the situation, not coming to the hospital, conversion into teleconsultations, and using the app. On the right-hand side, you can see a standard operation procedure that we send to the patient that is really easy to follow, with steps how to download and activate the app. And this really was also then confirmed with the case coordinator during the telephone consultation prior to their, not the consultation, but the initiation, I should say, to really explain and provide patients with instruction and education. And this comes down again to engaging with the patients and involving them in their care process and empowering them to undertake self-management. Well, after the first initial contact with the case coordinator, the patient started the on-demand prescription of the application. So starting the measures, and all measures would go into a secured cloud that then would be accessible through a physician web portal to prepare for and look into during teleconsultations. Now, if we look into this web portal, this is what the physician or the AF nurse would see. So every dot represents a measurement. So in fact, so this patient has been measuring for 2.5 weeks approximately, but normally you would say 7 days of measurements. Every dot is a measurement. The green dots represent sinus rhythm. The red dots represent an urgent matter, and this is mostly atrial fibrillation. The blue dots represent low quality and no measure at all, actually. And within the dots, there's a number representing the heart rate. And it is not mentioned here, but patients could also add here if they had any symptoms during their measurement. Now, if we touch on one of these sinus rhythm measures, then we can see here a 60-second PPG signal as measured by the patient. And we can see that this is very nicely regular. And we can see here an R tachogram on one straight line almost, indicating this is sinus rhythm and this looks normal. Would like to introduce you to the team who initiated that. So I referred to Dr. Dominic Lins, who's a cardiologist. Nikki Ploimakers is in master. She's a PhD student. We work closely together with Lars Grieten, who is the CEO from FibriCheck, and Graça Costa is from Biosense Webster, and she supported us in having this infrastructure available. This was really fantastic to work with these people because we provided this infrastructure for free to other centers in Europe, because I also realized during the COVID-19 situation, the power of social media, and in this case, Twitter, because the tweet that we see here from Dominic Lins is 2 weeks after the initial tweet that I just showed you before, to say, okay, we're 2 weeks into this now, and we have now established Telecheck AF in Maastricht in the Netherlands. He did a tutorial on how this would work and how other centers could benefit from this. And then it was picked up very fast by a lot of centers, and they were interested in that. And what we did with these centers is that we did a Zoom initiation call to really set them up with the technology and to tell them how this would work. And you can see here the team in action during an initiation call for Telecheck AF. We're now 13 weeks into this, and the infrastructure is now being used in 36 centers throughout Europe, and almost 1,400 patients are using the technology and receiving continuity of care through teleconsultation and using this app, which is really fantastic. Some patient feedback in the final slides. We asked our patients how they thought about this approach, what they thought about using the app, and about 75% says, I am completely okay with this. I felt safe and I'm happy to use that. And just a minority of patients was not really happy with it. And also it's very interesting to look in the age distribution, because here we see that the majority of patients is above 60 years of age, as I referred to in the beginning of this presentation. And also the average number of measurements per age is in the highest age categories. And to give you a case, we're currently, there's a lady who is 92 years of age, and she is using FibriCheck with the help of her daughter without any problem. So I think the myth of patients who are aging cannot use technology is not completely true. So the next steps and the future implications of this, we're doing retrospective analysis of the experiences of patients and the healthcare providers at the moment. We've applied for ethics that we have obtained now here in the Netherlands, and we're preparing a randomized control trial where we are going to test the effect between the face-to-face outpatient visits versus teleconsultation and the use of the mHealth on-demand intervention. There's questions to be answered for in my post, I think, as well, and for Australia, because the FibriCheck app is now a CE mark and is now approved in Australia as well, I think since 2 weeks. So there might be, it might be worth to explore avenues for Telecheck AF in Australia and to embed that in the AF clinic. So we can develop potential new AF pathways for patients with atrial fibrillation, but we can also use this to monitor atrial fibrillation in patients living rural and remotely. And I think that would be a great opportunity as well. So to conclude, ladies and gentlemen, Alison, I believe strongly that integrated care is the approach to really reimagining the future AF care. I'm really enthusiastic about the eye care AF clinics to implement that and embed that in clinical practice, and then look into the specific roles that nurses and allied health professionals can have within the multidisciplinary team to conduct the trial. And as I just said before, to explore opportunities for implementing the TeleCheck AF infrastructure. And I'm really looking forward to start the collaboration with the multidisciplinary clinical and academic teams, and to look into the concepts of evidence-based practice and practice-based research to really together with the patient build an excellent caring future. Thank you very much.
Thank you, Jeroen. That was a wonderfully comprehensive presentation, and I think it really does reflect the vision and the passion of the Caring Futures Institute, where we're role modeling excellence in both clinical innovations and in research. Now, we do have a number of questions coming through, and before I sort of pose the first one to Jeroen, I'll just go through the way that we'll take the questions. So we have, just to remind those who are listening, our panel is Leo Maher, who's a distinguished retired cardiologist who has had a very long and distinguished career at the Royal Adelaide Hospital. We have Imelda Lynch, who's the CEO of the Heart Foundation, South Australia and Northern Territory. We have Donna Stevens, who is the Director of Nursing for the Callan Heart and Lung Programme. Prash Saunders, who is the Director for the Centre of Heart Rhythm Disorders. And Catherine Zeitz, who is our the clinical governance lead for Callan, but also an associate professor at Flinders University. Now, we have a number of questions coming through. The first one is actually from Jenny Richter, and Jenny asks a question which I will ask Jeroen to respond to, because it's directly linked to a part of your presentation. So if people keep their buttons mute, and then when I finish talking, I'll mute, and then Jeroen. So Jenny asks, personalized structured education is a great initiative. It's impressive that only 2 visits in 8 weeks were effective. Would more visits in the same period have a greater and longer term impact?
That's indeed a great question, I think. Unfortunately, we did not look into that, but I think there's a number of things that we need to keep in mind. There's also a cost involved in this intervention. So the nurses and pharmacists had to reach out to the patient. So I think, to keep it cost effective, that is something to consider as well. To only have two visits, I think it's quite impressive that the hospitalization reduced so much, and apparently patients were really reassured. I think more visits would also be suitable, but then tailored to individual patients. So if we have patients who don't really need that because they're completely well educated and know how to deal with that, I would say that is like over presenting, or you know what I mean. But I think like those patients who really require that, I think we could look into that a bit more as well. But maybe, Prash, maybe you have thoughts about that as well.
Yeah, I mean, I think that the HELP AF study was kind of unique. We didn't quite expect the dramatic result that we found with just 2 visits. The reality is 2 visits resulted in such a reduction in hospitalization that I don't think we can ignore it. The question is, can we deliver that in a cheaper form than what we did? Okay, so, and I'm not sure we can, because there's something special about going into the patient's own environment where they feel safe and delivering education, and it's tailored to them as opposed to a standard format that we're used to delivering care in. So I think this is something that we need to explore further in how best can we get our messages across to the patient or the person who's actually having to manage their disease.
Absolutely, and I think it's in the era of personalized medicine, we shouldn't really be surprised if personalized education in one's own home has better effect than standardizing and making the patients come to us. Now we have another question, which is from Deb Wright, and Deb asks, and I'm going to ask Prash and Donna and Jeroen to respond to this one. At this stage, are you only taking referrals into the iCare AF clinic at the RAH from the RAH patient population? So the interest is already hurtling across South Australia.
I think, well, I think you said like the RAH population. Yes, so we're starting at the RAH population, but we have been testing this intervention at the Cardiovascular Center in Norwood in precious rooms as well. The plan is actually to really have it well established in the Royal Adelaide Hospital, and once it functions well there, then to spread it out across the state, interstate, and potentially even further.
I think let me follow through on that. So, I mean, I guess the Royal Adelaide, we've had some trouble in terms of the COVID situation and the ability to run research programs in an outpatient setting, and we're just restarting that capability. We've run now a nurse-led clinic looking at this integrated care approach now for a couple of years. At the Cardiovascular Center, and we've been taking direct referrals into the nurse clinic. Some cardiologists are using that as using the nurse for the education and for the risk factor management. Others have referred the patient completely over to our clinic. But Jeroen and Celine Gallagher have been running those clinics effectively. We hope to transfer it into the Royal Adelaide as soon as we possibly can. In terms of this study, as soon as we have adequate space and we're safe to do it from a COVID perspective.
Thank you, Prash. Donna, do you want to add anything to this particular question?
Yeah, I think my comment would be exactly, I mean, post-COVID, we're very keen to actually sort of have the opportunity to set things up at the Royal Adelaide as a start, and as Jeroen said, make sure that we can embed it in our practice. You know, Prash and Jeroen have been in this space, so we need to sort of start it off in Carlin. And I'm conscious that Deb's probably thinking of the Queen Elizabeth as well, which is part of heart and lung. So I think, you know, the opportunity obviously for us would be to start at the Royal Adelaide and then obviously roll it out across our program, and then hopefully further, you know, out into country and primary and yeah, other LHNs.
And I think that's what's so serendipitous about the Maastricht initiative, where we're already gathering evidence about the ease with which a population who needs good, regular, constant and rigorous monitoring will embrace a new technology. And Imelda, I want to ask you a question, and it's really as an experienced CEO and someone who has a nursing background, you will probably not be unfamiliar with Florence Nightingale's comment, where she predicted that by the year 2000 we wouldn't need hospitals because everybody would be able to be cared for at home. Now, ironically, her prediction might come closer to reality than she ever imagined, and it would be nice at her 200th birthday celebration that we can see the tides turning. But I would like to ask you, you know, the changing models of care that COVID will inevitably bring, from the Heart Foundation's perspective, how can we build on this integrated care model, on the better use of technology and greater interdisciplinary working?
Yeah, and thanks, Alison. I think the COVID pandemic has certainly hastened things that have been on government's agenda for a long time, and telehealth is a really good example of that, that's been talked about and sitting around for quite some time. But we've actually managed to get that up and running and working reasonably well across the state. I understand that there's still some technology issues that need to be addressed, and also some experience issues. People aren't familiar with using that yet. But I think that's certainly a really good example of how we can provide good access to regional and rural people. I had an example just the other week where someone said that they were coming down for some, from Port Augusta for some prostate cancer treatment, and they needed to have surgery, but they had to drive the 4-hour trip the week before to see the anaesthetist. Then they could go back home, and then they had to come. I mean, that sort of thing in this day and age is absolutely ridiculous. So we certainly need to start putting the patient back into the centre of the care and thinking about innovative ways to bring services to the patient rather than vice versa. We will always need the big centres in metropolitan areas, but we do certainly could use this integrated care model to service our rural regional people a lot better than what we currently do.
Thank you. I'm going to ask Leo a question now. We have a couple more coming in, but I'll go for this particular question for you, Leo. This inaugural chair, as we've all heard, bears your name. So what advice would you give Jeroen in making the chair not only known in Royal Adelaide Hospital in South Australia, but nationally and internationally, that would bear the hallmarks of an outstanding cardiologist and an outstanding nurse? So what advice would you give this young guy?
Well, Alison, that's very hard. I'm very honoured, of course, to be have this chair named after me. I've seen Prash and his team, including Jeroen and a lot of other researchers, do an enormous amount of work in atrial fibrillation. And a lot of it ends up in clinical trials, and I think that's what they have to keep doing, is the clinical trials. And you can't run good clinical trials without good clinical nurses, because nurses, one of the ways about trials is you have to stick absolutely to protocol. Doctors are terrible at doing that, but nurses are very good, and I think that's why they've been very successful. And I think they're doing some tremendous work, and just what they've picked up in the Netherlands recently during the COVID-19, how you can measure atrial fibrillation using wearable equipment, I think is fantastic. But I've seen enormous changes in this area. When I first started as a medical student, someone came in with atrial fibrillation, they were given a tablet of digoxin and told to go away. And but now it's tremendously advanced disease. And I think they just keep doing it. I haven't got anything to do except just work hard at it.
Thank you. And probably, you know, unfortunately, there are probably some patients who are just given a digoxin tablet and told to go away somewhere in the world. Okay, so we've got another question from Amanda Tovel. And Amanda says, I would be interested to know how the iCare AF trials and clinic might accommodate a patient with AF and other complex comorbidities. Would they be excluded, or would attempts be made to engage with additional treating clinicians, for example, dietitian, mental health care providers? Now, who would like to, again, Jeroen, and then maybe Donna to respond to that one?
Happy to respond to that. I think, you know, it is really about a multidisciplinary team approach, and that is really based on the individual case. So if we have a straightforward patient with atrial fibrillation and nothing else, which is not really likely, you know, I think you can deal with a small multidisciplinary team, for example, a cardiologist and a nurse But if there's much more happening, more underlying conditions, as the person in the question states, I think we need to reach out to other disciplines as well. From experience in the Netherlands, we had multidisciplinary meetings where we had like multiple specialists, including the nurses involved, discussing the individual patient case, and really from all the perspectives getting like the suggestions, what would be the most optimal treatment. And I think that is what we really should be doing in this new clinic. But from experience in precious rooms, what we do there is we work closely with exercise specialists to really see, you know, what is the capability of the patient, what can we provide them. There's nurses, there's cardiologists, so it's really a multidisciplinary approach. And Presh, maybe you have more to add to that.
Yeah, I mean, I think Jeroen's actually summarized that really well. We need to include people who are going to be important for that given patient. And for the vast majority, it may not require anything more than the team that we've constructed, but there are going to be some people who do need other input. And, you know, we've involved endocrinologists as we've required. We've had diabetic educators as we've required. Sleep physicians are obviously intensely involved in the program. And how you choose to do that may vary from institution to institution. You know, it may all have to be under the one umbrella with a multidisciplinary clinic where everyone sits and discusses the patient, or it may evolve the way we have, where we have defined referral channels to people who know the program and actually respond in exactly the way. So that's a unified message to the person. You don't all have to be in the same room at the same time. We do have some discussion for the difficult person where there are issues that we need to work through. And that's how we've set up. And I think it'll defer depending on which institution we're dealing with.
Thanks, Prash. Donna, do you have anything to add? And then I've got a question for you, Donna. So I'll let you respond and then I'll fire the question.
Yeah, I think it's similar to what Jeroen and Prash have said, but I think it creates opportunity. And certainly we've been having the conversations with Emily, who is our nurse lead in outpatients, about how we can look at this broader. And as Jeroen had said, we can look at this for other chronic diseases. But certainly I would think, you know, in the heart and lung program, I mean, sleep is part of our program, for example, but we could also integrate other areas as required, like diabetes, endocrine, etc. So, you know, I think it's how we set it up, and we bring them in as needed. We also have a strong Indigenous population, and we are looking a lot in the heart and lung program at opportunistic screening and other things. And so, you know, there may be some opportunities to integrate some of those things as we move forward. And we have an Aboriginal health nurse consultant, and a practitioner. So it's exciting times. I think there'll be some good opportunities.
Absolutely. And again, what we know from research that we're doing around the Centre for Research Excellence in Aging and Healthy Aging and Frailty, that the four biggest predictors of keeping healthy for as long as you can are making sure you eat the right stuff, so good nutrition, making sure you move, good exercise, social interaction, and sleep. And so if those are the four pillars of optimizing capability, then, you know, it might be interesting to see how we could always have those four things checked out and all part of our normal interaction. And I suppose on that, Donna, what's interesting is that eating, moving, sleeping, and chatting to each other, I would call those fundamentals of care. Those are the things that everybody needs, independent of you know, what clinical condition you've got. So I would like to ask you as a nurse leader, you know, how do we ensure that we don't forget the fundamentals of care and that we actually recognize and value the absolutely important, as Leo said, the really important attention to detail that many nurses and allied health professionals have without possibly the opportunity to do research. So, you know, how do you keep fundamentals of care central, but yet help nurses and allied health professionals develop a stronger awareness of good research?
Well, I think that, thanks, Alison. I think that's probably the challenge we have moving forward, and this does create opportunities. I think it's really important to understand the needs of the patient and the patient experience in all of this, and what their needs are as well. We absolutely need to look at the comprehensive needs of the patient. That is a challenge that we face frequently with the feedback we get from patients and families is that, you know, this bit was missed, or we didn't quite integrate X or Y. So I think it's something that we certainly need to address in thinking about that. And as we remodel our nursing practices, I think Jeroen's clinic will give us an opportunity to rethink that. We have a lot of chronic disease clinics. You know, we have nurse practitioners, but it's about how we integrate that into exactly what are the needs, and then carry that on out into build those relationships with country, rural, you know, other LHNs and primary care, I think.
Well, that's a wonderful segue, because I was just about to move into the clinical governance space for Catherine. And I can see Imelda, do you want to say something as well? I think I'll ask you both this question. So, and it's really what Donna said, that we're painting, you know, it's easy to disaggregate stuff, but it's very hard to build it all back up again in a way that that people understand. So integrated care is the flavor of the month, but as we have just experienced, it's hard to get right. So Catherine, how would you start to plan this renaissance, this transformation in the way that we do things, and after atrial fibrillation, what would be the top other 3 conditions that you would be trying to get a similar partnership running with ourselves or with other universities?
Well, that's a bit of a double barrel there, Alison. I think, although I prefer that question to Donna's question, because I would have struggled with that one. I think our experience, having just and still in the COVID pandemic, has really taught us how quickly we can change if we really want to. And there's no doubt that COVID has provided us with a platform. Here in Central Adelaide, we're talking about our reset, because we did empty out the hospitals, we did move care out. Our telehealth rates for the last 6 months of last year were less than 8%. And for the 3 months sort of heightened COVID, we've been able to sustain telehealth at 40%. And yes, to Imelda's point, the platforms are ugly. There's been telephone calls, there's been all sorts of creative ways, but we've seen fundamental change to the way that we do our work. And so repacking it and rebuilding it is really important. And we're almost at this sort of pinnacle point about we can just slip back to the old ways of doing it, or we can embrace the new ways of doing it. And I think, you know, there's no doubt that nursing in particular, but certainly some of our other allied health professions, really are our opportunity to change the way that we've been thinking about traditional medicine. And I think it's important because these complicated patients have multiple comorbidities. They no longer just have a cardiology problem or a nephrology problem or an endocrine problem. They tend to have 3 or 4 comorbidities that cuts across the traditional ways that medicine and often acute care has been provided. So I think that that's where the opportunities are. Which are the top three? Tricky bit. I think Donna mentioned, you know, diabetes. Again, diabetes cuts across the platform. I think a lot of what we're seeing around, you know, some of the renal and cancer work, they are large volumes of populations where I think nursing, and in particular some of that, to Leo's point, that sort of pathways to care. It doesn't take away precision medicine, tailored care to optimise the consumer experience and outcome. But that, you know, I work on an 80-20 rule. A lot of this, 80% of the time, is very similar, and it's only the 20% that we need to tweak.
Excellent. And Prash, I know I wouldn't want you to feel that you didn't have your own question as well. And certainly, as I still remember that very first day, you walked into my office. I think Jeroen was there, but you had just come out of the diagnostic suite and you were in your scrubs, and you sort of sat down. I was Dean of Nursing at another university at that stage, and you said, Alison, I think we need to do something together, and I've got this person, Jeroen, and she's doing wonderful things, and we really need to set all of this team up, and you were really quite inspirational and forceful to equal measure. But look, I'm going to ask you the curvy question. What makes for a high-performing integrated care team? Like, so what do you look for, and what do you model in your leadership in making these things happen?
That's tough. I was waiting for the question part of that. So look, I think it's a team. The team is a crucial component. The team has to be able to work together, and the team needs to have a unified goal. And so I think that's going to be the crucial thing here, especially as Jeroen starts to work on building up a nursing team that is going to work with him and potentially move outside the AF space, you know, encompass heart failure, some of the acute coronary syndrome rehab type work, which hasn't defined itself as well as what we've been able to do so far. I think he needs to have all the nurses on the same page and show the leadership on motivating those people to work with him. So I mean, he's seen how it works. He's been part of the team. I think this is hopefully set the foundations for really a successful growth from here in. So.
Absolutely, and again, I'd just like to acknowledge everyone of our panelists have been great supporters and allies, both for patient care, for achieving transformation and change in systems, and for having that determination to keep on. And I reckon that now that we've made some of these moves, the rate of change will be quicker. So I'm going to do a final roundup, and it's a question that several people have also referred to or alluded to, but I would just like each panelist to sort of give me what the top 3 things that will change for the better. So the top 3 things that will change for the better as a result of our experience of managing COVID. Okay, so again, some of you alluded to the fear that we'll go back to our own practices. So think of the 3 things that you really want to change, stay changed, and flourish as a result of what we've all gone through. And I'm going to ask Leo to start, because Leo, you're at the top left-hand corner of my screen, so that's where you always start. Then I'm going to Jeroen, then Imelda, then Prash, then Donna, and then Catherine.
I'll start now. I think the best thing they could have is what we're seeing in the business is working from home. And I think the communications are been tremendous. A meeting like this would have been impossible a few years ago. The communication so you can talk to the patients. The other thing is developing the nursing teams, which I've seen Prash and Jeroen do is tremendous. But one of the caveats about that, one of the slides that Jeroen showed, was that if you don't train the nurses properly, they do worse than the usual care. So I think that how you do that in a dispersed country like this, I don't know. It's a highly centralised country, but how do you do this well in the bush? I don't know, in the regional areas. But I think it can be done, and I think sometimes it's a matter of training the nurses and maybe even having travelling nurses out to do that sort of thing. So I would hope that would come out of it.
Jeroen?
I was actually thinking about communication as well, and it's like more or less a repeat of what Leo said, but I think looking at this period of COVID-19, how easy it was to communicate with people, like colleagues, but also with patients and others, that was really fantastic. And I think that is what we should utilize much more. Also, like telemonitoring or teleconsultation, video consultation for those patients living far away, as Imelda just gave that example. I think that's really important. The other one is the speed of implementation. I've seen, like with the example here in Maastricht, we had that up and running within 2 weeks. I must admit that they now came back to us and said, like, okay, we need some documents here. But I think, sometimes the implementation processes are really long, and I think we can just, like, if we combine that with communication, we can reduce that. And again, involving patients. I think if we keep on having the patients more or less on the team, I think that is really important to improve outcomes.
Excellent, thank you. Imelda?
Thanks, Alison. I think because I'm at the Heart Foundation, I have to say that people have gotten outside and undertaken more physical activity maybe than they normally would. And especially to Leo's point, using that commute time instead of sitting in a car, they've actually taken some physical exercise, which is brilliant. I think the other thing that I hope stays is the resilience, the teamwork and the gratitude that we've had around our health service professionals and the systems and the people that support that. And the final one, I know it won't happen, but I would love to see the bipartisan government support remain, but I don't think that will happen.
You're such an idealist. Yeah. Okay, Prash.
I think I'd hope telehealth remains. I think that's going to be crucial. We're now probably 95% telehealth, and our patients are preferring the telehealth. The opportunity to actually speak to them in their environment with their family is something that expands our clinical interaction more than I expected. I expected it to be a block. And the second clinical one would be the remote monitoring of devices. I think this has been a fabulous uptake, something that we had several stumbling blocks on previously, but has really redefined how we're managing patients with pacemakers and defibrillators. That's been huge, and I think that's going to be here to stay. And I think the third amazing thing has been the education programs. So that we've had the emergence of international education programs where we can actually have all our fellows, all of our teams on, and speakers from around the world readily access. And we're having this almost twice a week now, which is, the need to travel for international meetings may be changing. And I think that's a strong positive as well.
Yeah, and it will improve our carbon footprint without doubt as well. So Donna, and then final comment from Catherine.
Well, I guess my things are a bit broader, but I think, I've been excited about this whole opportunity to combine research and practice and have a more collaborative relationship with universities. And I think for nursing that there has been a gap with us doing that. And certainly I think here in Carlin, for us to be an exemplar site, we really need to encourage that. So I think, COVID times has probably escalated that even more. And I think events like this are absolutely fantastic, but also that we can actually integrate the resources we have within Carlin already and develop different models of how nurse consultants work, for example, nurse practitioners. So I think that's the first thing for me. The other thing is the opportunity to strengthen the collaboration with, not only with other LHNs within South Australia, but more broadly. And as Prash said, being able to connect all over the world is very exciting. And even myself, I've noticed the access to education and online things has been fantastic, and things that have come from the Heart Foundation and other NGOs have been terrific in terms of being able to connect. So I think that that's really exciting. And lastly, I think the opportunity to better empower our patients in different ways. And I think what Jeroen was saying about, even the older population are not afraid of the technology. We think they are, but they're actually not. If you simplify it and you give them good, simple instructions, it is possible. Continuing with 40% telehealth and getting that higher and higher, I think is a great opportunity, and it will just strengthen nursing practice and the way we address things in nursing. And certainly in the year of the nurse in 2020, I'd like to see that be escalated further so that we can be delivering some quality care.
My 3 is probably care closer to home. I think it's not just care in the home, but care away from the large institutions that we have. And I do reflect on Imelda's story about patients coming from Port Augusta, that those people and the cost to those people to travel down. So I think that would be one. I think recognising Florence Nightingale's year, washing your hands. Such a simple thing. And yet we know already that the rates of influenza, the graphs that I've seen are just so amazingly low compared to the 5-year average we've had by social, not just washing your hands, but good, simple hygiene practices. I hope that remains with us. I think the other thing that I saw practically in COVID was a different style and way of clinical leadership. And what we saw was great clinical leadership with clinicians leaning in to do things differently, particularly around things that they may have resisted for some time. And again, I think the risk is to make sure that we continue having clinicians leading in and leading, and maybe not leaning out. That would be my 3.
Excellent. Leaning in rather than leaning out. That's awesome. That's a good catchphrase. Well, look, don't know the time it is, but I think we're sort of I think we've worked the panel pretty hard. It has been a wonderful opportunity to share thoughts, perspectives, and also to celebrate the inaugural sort of chair, the joint chair that bears Leo's name, that celebrates the first partnership between the College of Nursing and Health Sciences and the Caring Futures Institute and Callan. So there's a lot of firsts, there's a lot of innovation in this space, and we would hope through, again, what Catherine has said about the leaning in rather than leaning out, the leadership that can transform care, and the focus on using technology to absolutely help us provide a much more person-centered approach to our care. These are all things that we should celebrate and embrace in this 200th year of celebrating Florence Nightingale's birth. So I would just personally like to thank each of you for giving up your very precious time. This has been recorded, so it will be accessible through the Flinders Caring Futures website. and we'll also tweet and blog it. I will be relying on other people to do that because my tweeting skills are not as they should be. So that just illustrates that everybody has major areas for improvement. So I'd like to thank you all. Have a wonderful evening. I'm going to go home and have my one glass of red wine. And Jeroen, now's the time for that very big, heavy Dutch coffee. So thank you all, everybody. Thank you. Bye-bye.
Thank you.